It's Dr. Conrad Aquino again at Monse-Heart. And in this session, we're going to talk about diabetes mellitus. Now, since this is the very first session of a library of our medical series, we're going to kind of walk you through this one to try to show you how to learn the right way and kind of the structure, so to say, of how these sessions will look like for you. First, we talk about pathophysiology. In diabetes, for cells to use up glucose, they first need to pull that glucose from the blood into the cells, and they go through certain gates in the membrane of the cells. Now, these gates are usually closed unless you have a key. Now, that key is called insulin. Insulin comes in, puts the key in, opens the gate, and glucose can now come in. And that's how glucose is used by your cells. Now, the deficiency in diabetes could be the key, the insulin, or the gates on your cell membrane. Now, your type 1 diabetes, which you will see in younger individuals, is a key problem. They do not have enough insulin that is produced by your pancreas. Type 2 diabetes, on the other hand, will take quite a while longer for it to develop, and you will see this in older adults. And it's a gate problem. So even though they may have a key, the gates may not fully function the right way. And because we have several gates on the cells, it is not simply that every gate will be malfunctioning. So it could start one at a time. And so the diabetes type 2 is more of a progressive type of disease. Now, the result in this, if either you don't have a key or you have a faulty gate, is that glucose remains in the blood. And glucose starts to go high, and this is called your blood sugar levels. And when your blood sugar levels are high, this is how they diagnose you with diabetes. They could either do a random blood sugar that is higher than 200 milligrams per deciliter. It could be a fasting blood sugar in separate occasions that is more than 126 milligrams per deciliter. It could be so many different things, but it's basically trying to find that sugar. So I'd like you to now focus on this one thing here. This is kind of the glue that holds everything together. This is what we called earlier as the corpus callosum cross. Now, imagine this. Imagine a cup of water, okay, and you pour a large amount of sugar in it. What happens to the water? It becomes thick and viscous, right? It becomes like maple syrup, or molasses or honey. Think about that. Now, that's what happens to our blood when our sugar is super high, right? It becomes thick and viscous like pancake syrup. Now, imagine how hard it is to pump out that maple syrupy honey kind of blood from the heart, where you're trying to really push that thick, syrupy blood out. It's going to be way difficult. So, next thing we talk about are symptoms. Symptoms for diabetes is, one, you're hungry because the cells are not able to use that glucose. It feels like it needs more. Although it's available there, it's in the blood, yes, but the cells don't see it because despite having a key, the gates might be faulty, or maybe you don't have the key and the glucose just doesn't come in the gate. And so you feel hungry, you feel fatigued because there's no glucose to use. Another could be that you're thirsty. Having a thick, syrupy kind of blood makes, it so viscous that it doesn't feel like there's water in your blood. Of course there is, but it doesn't feel like it. And so you feel that thirst. It's feel like you need to quench that thirst. You feel dry because of that. Another is urinating so much. Okay. Now, when We urinate when our blood glucose levels exceed 180 milligrams per deciliter. The glucose goes out into the kidneys, and guess what happens? It brings water with it. So when it exceeds that much, we tend to urinate that often. So you will see a lot of diabetic people that are complaining that they pee so much, especially if their blood glucose levels are not controlled. All right, so let's talk about complications now. Now, again, think about that thick, syrupy, honey like type of blood. People with diabetes are twice as likely to have a heart attack and or a stroke. Now, why is that? Now, remember what causes a heart attack or a stroke. It's blockages in your blood because of fat deposits, and then eventually it will narrow down and it could cause clots as well. Now, think about the thick, syrupy blood. It's going to be very, very sluggish. It's going to be slow blood. It's going to be sluggish. Even though you're trying to push that, it's going to be sluggish. And because of this sluggish nature now of the blood, it's easier to have fat deposit onto those arteries that go into the heart and into the brain. So that's why you're going to see a higher likelihood of heart attacks and strokes in people with uncontrolled diabetes. Now, another complication is a diabetic foot wound. Now, let me share you one quick anecdote. There was a nurse that came to me, showed me a picture of a diabetic foot wound, and asked me, "Hey doc, here's a picture of a wound. What dressing should I put, and how often should I dress it?" So I asked, "Well, how's the diabetes?" "I don't know. I just need to know what dressing I should put and how often should I dress it." "Well, okay, so how are the blood sugars?" "I don't know. I just need to know what dressing I should put and how often should I dress it." Well, we're missing the whole point here. The point of a diabetic wound is there's a first word to it, diabetic, right? Which, if we do not take care of the diabetes, then we will not be able to take care of the wound. Why? Let me show you why. Now, again, imagine that syrupy blood. The further it is from the heart, now the harder it is for the heart to pump that. The smaller the arteries, the harder it is for the heart to pump out that honey-like blood, right? And guess where these wounds are? It's the furthest in the heart, right? And the smallest arteries is also the furthest from the heart, which is in your foot, on your toes. And that's why when they go to wound centers, the wound centers will try to debride the wound until they get good tissue. And what's good tissue? Tissue with good blood flow. And that's really as simple as that. Good blood flow will get that wound healing in no time. And the problem with diabetes is they have poor blood flow. And that's why we need to bring down those blood sugars so that the blood will flow easier, right? Simple. Now, another complication is neuropathy. Neuropathy is when your nerves are starting to fail you. You can't feel your toes or your fingers, usually your extremities. Most of often, the first thing to go are, again, furthest from your heart because of your toes. Now, I'd like to again, imagine this. Now, think of a long road trip where you've sat in a car or a bus or whatever it is for a long period of time. And then after that long road trip, you get up, right? What happens? You feel kind of that blood flowing into your lower extremities, your legs, your feet, and you feel that tingling sensation in your feet, like the prickly needles that you feel. It's that blood going back again into those extremities, into your toes. And that's what happens with diabetes. And that's why they are starting to feel that tingly sensation. They are unable to feel much in their toes, is because, again, your blood flow. Another complication of poor blood flow is when you have the smallest, the tiniest capillaries or arteries. And where are those organs? Those tiniest ones can be found in their kidneys and in your eyes. And that's why in diabetics, you will find a lot of kidney problems, kidney failures, because of the low blood flow. And if it's not pushing in that blood into your kidneys, then those cells are going to die. Same thing with your eyes. With your eyes, have the tiniest of capillaries. So if you are unable to put that blood flow there, then those cells will start to die. And that is why annually, the people with diabetes are much prone and must have those annual eye exams. So this is something that you will see is really, truly, so simple as you can see the corpus callosum cross of a concept that of blood sugar, the concept of syrupy blood, the concept of honey-like blood that is as simple as just having poor blood flow, giving all these complications that we've just enumerated. All right, so now let's talk about treatment. What is the initial treatment of diabetes? Initial treatment diabetes is diet and exercise. Okay, so not rocket science, but let's talk about diet for a while here. So diet is usually, we try to tell our patients to, lay off of the sweets, right? But I'd like you not just to think about sweets. Now, table sugar, which is what we use to bake sweet stuff, like donuts or cake or what have you, is just mainly called, it's a chemical compound called sucrose. Sucrose actually only has 2 glucose molecules in every 1 molecule of sucrose. And it does taste sweet, yes. However, there are other sources of glucose that the patient might not be aware of. And what is that? Starch. Starchy foods contain a lot of glucose. 1 starch molecule has 300 to 500 glucose molecules in just 1 starch molecule. Where do we find starch? You named it. Rice, potatoes, corn, bread, all of that will contain a lot of starch in it. And of course, the 300 to 500 plus glucose molecules in each starch molecule. And that is what we will need to try to help kind of, lower down. And one quick tip for the bedside, we can't tell the patient to simply let go of the donuts, especially if they take a dozen donuts a week. We can't simply tell them that, hey, you have to stop eating your donuts because now you're diagnosed with diabetes. Now, just like with anyone, if we just try to do a diet, how many of us have tried to do any diet and failed, right? And we're healthy. Now, people who are unhealthy will have a harder time doing so. So we try to let them know, we try to cut down on the donuts. Maybe if they're taking 12 donuts a week, let's try to get it down to 11. And then from 11, we get it down to 10, and so forth and so on. And maybe the goal is 6. Who knows? Maybe the goal is 7. It could be 7, 1 a day instead of 2 a day, right? So that could be the goal. All right. Now, that aside, let's go back to diet and exercise. We talked about diet. Now let's talk about exercise. For exercise, when we do a lot of these physical exercise, it actually helps our cells increase the sensitivity of the gates. So even if there's just a small amount of insulin, the gates are now more sensitive to the key that it will start to open up and the glucose starts to come in. And that's what exercise do. So it kind of helps decrease that blood sugar in that manner. All right, now time to talk about medications. Now for medications, there are several mechanisms of action for the several types of medications. The number one medication that you can probably recall is insulin, right? Diabetes, insulin kind of goes hand in hand. Not always. For your type 1 diabetes, where you have a key problem, where you truly have a low amount of insulin being produced in your pancreas, then yes, insulin is the solution. You have low insulin, you give them insulin. Simple as that. For people who have a gait problem, your type 2 diabetes, you try other medications first. You try oral hypoglycemics, and they work to, number one, they try to decrease intestinal absorption of glucose into the blood. They also help decrease liver release of glucose, because as we know that our liver stores a large amount of glycogen. Glycogen is the storage form of glucose in our body. So it decreases the liver trying to release that. And some medications can also help increase the sensitivity of the gates, so that just like in exercise, it increases the sensitivity. So even a small amount of insulin will help open those gates up. Another way that medications work is it stimulates your pancreas, your beta cells in your pancreas, to increase production of insulin. And of course, you have insulin. So all of these methods, we try different ways to try to help decrease that blood sugar. Now, one thing that you will need to know is side effect. What are the side effects of medications? Because if you give too much, it's going to be unsafe for the patient. You want to treat the diabetes, yes, you want to lower the blood sugar, but you don't want to push it into a level that is now unsafe for the patient. So, same nurse that I talked to you about, I asked the patient, I asked the nurse, what is the side effect of the medication? And she said, well, I don't really know. Um, well, um, I had to memorize that when I was in nursing school, but I don't really recall all of that. Okay, so let's start with this. What's the effect of the medication? Whether it's insulin or oral hypoglycemic, what is it supposed to do? Well, it's supposed to lower blood sugar. Okay, so what's the side effect? I don't know. I don't remember. Okay, so what is it supposed to do again? Well, it's supposed to lower blood sugar, right? Okay, so what's the side effect? Well, I don't know. Well, as simple as it is, the effect is the most common side effect. And when it lowers blood sugar, the side effect is hypoglycemia. It's a low blood sugar level. And it's as simple as that. Just like with any type of medication. Let's say you're hypertensive type of medication. You have blood pressure pills. What's it for? It's to decrease the blood pressure. What's the most common side effect? Low blood pressure. Simple as that. And things that you don't have to memorize, as long as you know what it's for, then you automatically know what the most common side effect is. Now, of course, there will be exceptions to the rule, but for the most part, this will be your simple and easy way not to need to memorize. If you understand the key concepts within these diagnoses, the pathophysiology, you will understand the symptoms, you will understand the complications, you will understand treatment, medications, and all of those side effects. And you can see now, I'm going to challenge you to try to forget as much as you can what you just learned today in this session of diabetes. Now, it's going to be tough. So, this is the Monse-Heart method. We try to create that corpus callosum cross from the left side of the brain to the right side of the brain, so that it's easier for you to be able to understand that and also to be able to apply that. So when you encounter not just your tests, but in patients that you see, oh, this is a side effect of the medication. Oh, hey, you have diabetes. Now let me show you all of this information. And the information is not just for you to be able to pass those tests. Again, now, for the same nurse that we were talking about, I have explained to her something similar to this, what I've explained to you now. And I just not only gave her the tool to understand, but I gave her a tool to be able to explain to the patient, so that the patient can now understand why his wound is not healing in the first place. And now every time he tries to eat bread or potatoes or anything sweet, he's going to think, oh man, I'm going to have high blood sugar. It's going to be thick and viscous. My blood will, and now it's not going to reach my foot and it's not going to heal. So with that mental image in mind, it's going to be simpler and easier as well for patients to comply. Compliance goes up and patient outcomes are improved. So I hope you like the way that we do it, and we're hoping to see you in our further sessions next. Thank you.